Good evening, everyone. Yeah, for all those who are new today, we are going to start off today with the presentation of parotid. It's basically a short case. The case commonly put are the swelling, not the parotid case per se. So we can ask this case in the swelling. There are a variety of swellings which can be covered. Commonly put swellings are parotid swellings. Apart from that, there are swellings like lipoma and sebaceous and dermoid. These are the three or four swellings that are commonly put. We'll wait for a few seconds and start off with the case. I would like to go again over the theory part in the first few minutes with you so that I can make you understand what all things to ask. I find that it's a better way to start off with the theory so that you can understand what are the differential diagnoses and what are the various symptoms that we have to rule out before going on to the examination. Okay. Hello. Uh, is my voice coming clearly? Hello.
Yes, sir.
Okay. Okay. So we will start off with the case of a swelling. The basic points of swelling apply over here. And apart from that, we cover a majority of the theory portion in the parotids as well, as well as the salivary glands per se, so that you don't have to read that topics. These topics are essentially very important when it comes to NEET because a lot of one-liners comes from the parotid and the submandibular glands, as well as generally one of the 3 or 4 markers come from the parotid gland, either pleomorphic adenoma or a submandibular gland stone or something like that. So it's an important topic both ways. So we'll start off with that. Okay. So uh, now the basic format by which we'll be going is that we'll first of all go through the certain pathologies that are there and whatever. Hello, am I audible? A lot of people are telling I'm not audible. Please tell me if I'm not audible, then I can maybe check my network. Am I audible?
Yes, sir.
Okay. So as I said, start off with the theory part in a short manner so that you can understand what are you actually going to ask. Okay. So yeah. So basically, first of all, to understand the concept of parotid and submandibular glands, you have to understand the things that are present anatomically in the region of the parotid gland, and then you can go off differentiating what are the swellings present in the parotid gland, what is the pathologies present, and what are the features and the treatment asked, so on. So in a short manner, the parotid gland is present in the zone of a parotid region or a parotid zone. So what is the parotid zone? That's the first thing, and what are the boundaries of it, and where is it situated exactly? Okay. So the parotid zone is basically a zone which is made up of a rectangular zone. Rectangular zone is basically over here. This is the rectangular zone. The boundary of the rectangular zone are superiorly the zygomatic arch. The zygomatic arch is the superior boundary. The inferior boundary is a line passing through the angle of the mandible. Line passing through the angle of the mandible. Posteriorly, it is the master tip, and anteriorly, it is the midpoint of the zygomatic arch. Okay, zygomatic arch, midpoint of the zygomatic arch, mandible, and the master tip. Basically, the area below, behind, and somewhat in front of the ear is the parotid area, and all the swellings over here are classically referred to as parotid swellings. Okay, that's the first and the most important concepts that are parotid swellings and where are they classically located. Submandibular gland classically is located in, so as to say, the submandibular region that is present below or let's say inferior to the angle of mandible, also posterior to the angle of mandible, and located medially from the midline of the neck. Okay? And here there is no definitive margin, but interiorly we can say that the submandibular triangle forms the margin, but exteriorly or by surface landmarks there are no definitive margins. These are surface landmarks. Okay, so this is basically the different anatomical boundaries of both the parotid region and the submandibular region. Okay? Uh, Now, the second most important thing is the things that we encounter anatomy of the parotid gland per se, from the skin to the parotid gland to below it. Okay, starting off, the first thing that we encounter is skin, subq. After the skin and subcutaneous tissue is over, we start off with the fascias and a few arteries and nerves that are present in between those things. Okay, the skin, subcutaneous tissue, a superficial fascia in the parotid region. It is followed by a few nerves, a few veins, and the fascia of the parotid gland. Okay, the fascia of the parotid gland is basically nothing else but the part of the investing layer or the superficial layer of the deep cervical fascia. The deep cervical fascia has a variety of layers, one of which is known as the investing layer or the superficial layer. Okay, so after superficial fascia, there is the investing layer of the deep cervical fascia, which covers the parotid gland and forms a false capsule around it, followed by the true capsule around the parotid gland and the parotid gland itself. Below the parotid gland, there is generally the masseter muscle. Okay, so here in this region, there is the masseter muscle, the most inferior part. In front of the masseter muscle, there is a medial pterygoid muscle. Behind it, there is an almost mandible, from where the masseter muscle arises anatomically, if you recall it. So the mandible, the masseter muscle, the medial pterygoid muscle, the zygomatic arch. Again, the boundaries, the inferior, the posterior most boundaries are basically the floor, so as to say. After the masseter muscle comes, there is the parotid gland enclosed in the false capsule. There is the that is formed by the investing layer or the deep layer, investing layer of the deep cervical fascia. So the investing layer of the deep cervical fascia comes from here. It splits into two parts and encloses the parotid gland. Below it is the masseter muscle and the various structures. Above it is a few nerves, arteries, and above it is the skin subcu and the superficial fascia. So what are the nerves, arteries, and veins that are present in between these things is a very important thing to know, both in terms of the surgical way and the clinical examination. Okay. So superficially, after the skin and the superficial fascia ends, the first nerve that comes is the greater auricular nerve. Okay, the greater auricular nerve winds around the angle of the mandible and comes anteriorly above the parotid gland. This is followed by the nerves of the fascia, of the branches of the facial nerve. Okay, so we all know that the facial nerve is an important nerve. It starts from the stylomastoid foramen. Okay, it below the stylomastoid foramen is basically present below the between the angle of the mandible and the mastoid tip. Between these two things, there is inferiorly, if you see, there is stylomastoid foramen present. From where there the facial nerve winds around, comes from the posterior and the inferior aspect into the superior and the anterior aspect above the parotid gland or into the parotid gland, so as to say. So the posterior inferior border, it goes inside the parotid gland and it kind of divides the parotid gland into two parts, that is the superficial and the deep lobe. Okay, this is the basic anatomy of the parotid gland. So skin, subcutaneous, superficial fascia, followed by the greater auricular nerve, followed by the various layers of the deep cervical fascia, investing deep cervical fascia, inside the parotid gland, and the facial nerve that comes first inside the facial nerve, which divides into the superficial lobe and the deep lobe. Okay, so as such, the parotid gland end block is a single structure. Okay, there is no division in it. Just the facial nerve is arbitrarily dividing into superficial and deep lobe. So there are no actual lobes of the parotid gland contrasting to the submandibular gland, which is divided into two lobes by the mylohyoid muscle. Okay, so that is the difference. So there are just there is a single gland, but we arbitrarily divide the parotid gland into two lobes, the superficial lobe and the deep lobe by the facial nerve, which, as I said, enters from the posterior aspect, posterior inferior, coming in between, dividing into various branches and dividing the superficial and deep lobe of the parotid gland. Posterior to it is the retromandibular vein. This retromandibular vein is present posterior to the facial nerve. That is an important aspect. I will tell you why again. And posterior to it is the external carotid artery and its various branches, being superficial, temporal, and maxillary artery. Okay, so that is the posterior most part, and then the parotid gland ends, and then there is the masseter muscle and the angle of mandible and the bone coming in per se. Okay, so you need to understand the various layers of it. I'll show you a small slide for that. Okay, so this is a schematic diagram of the parotid gland. So if you all can see, this is the facial nerve, and then the posterior aspect. Here all the structures are not shown. So if we assume that there is the cytomuscular foramen present over here, it winds around it, comes from the posterior aspect and divides into superficial and deep lobe. The deep part is shown behind, the superficial part has been removed. Okay, per se we can say that. These are various branches of the facial nerve, and this is the retromandibular vein. It is formed by two divisions, the angular facial vein and the maxillary vein. So from the retromandibular vein, which is present behind the facial nerve, so as to say. Also behind this, yeah, again a schematic diagram of it. So this is the medial pterygoid and the mandible, the angle of mandible, so as to say a cross section, a mastoid present over here. If you take a cross section through this way, cross section, okay, so the facial nerve comes in and from the posterior part and exits from the anterior part, and these are the various arteries present. The external carotid and the carotid sheet present posterior most, but here there is the retromandibular vein, and here there are arteries present, which is not shown in the diagram. So this is how basically you divide anatomically the parotid gland. Okay, I hope you got a basic idea of the parotid gland. Where is it present? What are the layers above it? What is the nerves present? So basically the first thing present is the nerves, greater auricular and facial nerve, followed by the veins, and then the arteries. This is the sequence: nerve, vein, and arteries, superficial to deep. Okay, and the muscles present over there, and the area of the parotid gland. These things are important in terms of the surgical management of the parotid gland. That is why I'm explaining you all these things. And the most important takeaway apart from all these things is the facial nerve is present superior to the retromandibular vein in this area, superior to the retromandibular vein. So an important thing to know is there is a plane known as fascio-venous plane of Patty. Okay, so Patty is superficial fascio-venous plane. Basically, that is the plane at the level of the retromandibular vein, fascio-venous plane. So it's the venous plane, that is the retromandibular vein, along with the facial nerve from the fascio-venous plane of Patty, P-A-T-E-Y, and that is the plane above which we call the superficial dissection of the parotid lobe, and below which the deep. Anatomically, it is the facial nerve which divides it, but in terms of the surgical management, we divide it as the fascio-venous plane of Patty. Superficial to it is the superficial row. We remove everything in the superficial parotid. Okay. So fascio-venous plane of Patty. That is why I was explaining all this. Basic concept to understand is the vein comes below it and the nerve comes above it, and then the nerve divides into a variety of branches. Okay. So what are the branches of facial nerve? Can someone please tell me? Branches of facial nerve, terminal branches.
Is it temporal, zygomatic, and mandibular?
There are 5 branches, and there's something named. Someone tell me. Temporal, zygomatic, buccal, mandibular, cervical. Okay, and what is that known as?
Pes inferens.
Yeah.
Geese foot.
What is that? It's basically goose foot appearance. Someone said that. So summarize for everyone. The facial nerve, as shown in that diagram, divided into 5 branches in this manner. So this is the branch manner. So that is a goose foot. A goose foot has this way. Goose foot appearance. That is known as pes inferens. Yes. So, okay. So sorry, the spelling mistake with that. So the goose foot appearance, so basically 5 branches. This is also asked frequently. So the questions asked frequently till now are fascio-venous plane of Patty. The second, the branches, and what is this known as goose foot or pes inferens appearance. And the branches basically include either frontal or temporal, whatever you call that. Second is zygomatic, upper cervical, upper buccal, lower buccal, marginal mandibular, and cervical. So these are the 5 branches: frontal, zygomatic, upper buccal, lower buccal. That are there's the same branch, and marginal mandibular and cervical, the branches of the facial nerve. Okay, so this is basically all about the anatomy of parotid gland, all that is required. Submandibular gland in turn divided into 2 parts by the mylohyoid muscle, and it is related to variety of nerves. That is all you need to know in submandibular gland. It will also help. It is a common question also asked in the anatomy part of the NEET. That submandibular gland is divided into 2 parts by mylohyoid muscle, and nerves related to it are lingual and hypoglossal nerve. Okay, lingual nerve is present superiorly or anteriorly. That is, if there is a submandibular gland over here, superiorly and anteriorly is lingual nerve, and in the deeper part is the hypoglossal nerve. So 2 nerves, lingual and hypoglossal. Okay, and to end it, the parotid gland has a duct which is known as Stenson's duct, and the submandibular gland has the duct known as the Wharton's duct. The Stenson's duct is the parotid gland duct. It pierces the buccinator muscle. Okay, it pierces the buccinator muscle. It is over the masseter, so and the anterior part of the parotid gland, it is over the masseter muscle, pierces the buccinator muscle, and goes inside and opens at the second molar tooth, upper second molar tooth. Okay, so again, that's a very important thing to say. Yeah, so these things are asked in both anatomy as well as surgery in the practical of this NEET. So these are the basic revision of all that. if we move on to the pathologies of parotid gland, okay, as I tell always, any pathology of anything is divided into a variety of subheadings. So divided always that way. It can be a traumatic pathology, it can be an inflammatory pathology, it can be an infectious pathology, it can be a neoplastic pathology, or it can be some autoimmune pathology. So the same thing applies over here. As in all cases, there can be something that is more in one pathology, something that is less in variety of cases, but the basic classification always divide in your mind in this way. It is very easy for you. So for the parotid gland, there are basically major two things: an inflammatory pathology and a neoplastic pathology. There is very rare trauma of the parotid gland and very rare an autoimmune disease of the parotid gland. A common autoimmune disease in the very rare cause is something known as Sjogren's syndrome and sarcoidosis. So Sjogren's and sarcoidosis can cause enlargement of parotid gland, but these are very rare scenarios. You never speak these as the first cause anywhere. Okay, if you have to code the NEET part, then you can say that yes, Sjogren's is associated with parotid enlargement, Sjogren's and Mikulic's disease, but these things are rare. Just so as to cover, Sjogren's disease can be primary and secondary, and both are associated with parotid enlargement. Mikulic's disease is commonly the primary part of it, and also with parotid enlargement, there are a variety of things. The important thing is dry mouth and dry eyes. Sorry, basically there is xerostomia and keratoconjunctivitis sicca. That is what is known as Sjogren's syndrome. Okay, so just so as to cover it, it's never asked per se in the surgical part, but sometimes it is asked there. So that is why I've converted xerostomia and keratoconjunctivitis sicca. Okay. So that is what is the problem. So coming to parotid back, the two common pathologies are infectious and neoplastic. So can someone name one infectious pathology or inflammatory pathology, sorry, and one neoplastic pathology of the parotid gland, which is the most common infection you know associated with parotid gland?
Mumps.
Yes, very good. And the most common pathology that you know with parotid gland, neoplastic pathology?
Pleomorphic adenoma.
So as you all know, as you have all have already said it out, there are just two common pathologies known to you guys. So your basic aim, as I always tell, is to come to one diagnosis and to rule out all other diagnoses in any practical case. Okay, whether it be a thyroid swelling or a breast swelling. Like in a thyroid swelling, your aim is to rule out all other things apart from CA thyroid. Same in CA breast. For a stoma, as I said, to come down to some single pathology. Here the same thing. Your aim is to come down to either parotitis, that is mumps, or to pleomorphic adenoma. In your case, in surgery case, it is generally the pleomorphic adenoma that is present. Okay, but to rule out all other things, but the first thing you should rule out is you should put it in the category of either inflammatory or neoplastic. Okay, you have ruled out autoimmune because autoimmune things are very rare, so it is as such nothing to rule out. Okay, it comes in a specific criteria only. Autoimmune comes when there is bilateral swelling, there are association with, let's say, dry mouth, dry eyes, or polyarthritis or something like that. So autoimmune is already ruled out. Majority of the cases, if it is there, it's your luck, but you know those things. It won't come. In pleomorphic adenoma and parotitis, the basic difference is obviously pain and fever. Okay, so in a neoplasm, there is no pain and no fever, as well as compared to parotitis. There is always a pain and fever. Common inflammatory pathologies are viral parotitis, that is mumps, occurring in a young age group, and bilateral, commonly fever, myalgia, malaise, a URTI preceding it, and all those things. While the other pathology of inflammation is bacterial parotitis associated with something known as stone in the duct. Okay, so siloadenitis or stones in the duct of the salivary gland, that can be either a submandible or parotid gland, any of them. If we talk about parotid glands, stones are comparatively more common in the submandibular gland. Okay, so this is again a common question asked: why are stones more common in the submandibular gland and not in the parotid gland? So can someone answer that?
Because of drainage occurring against the gravity in submandibular gland.
Yes. Something apart from that, there are 2 or 3 points. So the first point is that. The second point,
Longer duct.
that's the same thing. The drainage is non-dependent drainage. So as to say in one word, the non-dependent drainage of submandibular gland, the duct goes from below to above. So it's a non-dependent, non-gravity against the gravity, and also there's a longer duct. So that's the same thing. So the drainage is non-dependent. The second thing is the secretions are more thick or viscous as compared to the parotid gland. Parotid gland is a dependent drainage, so it is like this. It goes down. So gravity helps it, so stones are not easily formed, and it is less viscous as compared to the submandibular gland. But if there is a stone in the parotid or the submandibular gland, it can block the duct and cause a type of pain. That is again something that is known as a colicky pain, as occurs in any structure. See, basically a colicky pain is something that waxes and wanes suddenly and occurs classically in a tubular structure. Ureteric colic is a stone in the ureter. So it waxes and wanes and occurs in a tubular structure. Similarly, in the duct, it's a duct tubular structure. There is a stone. So there is a sudden onset of pain, increase in sudden pain, and sudden decrease in pain. That's a colicky pain. There is a salivary colic or gustatory colic, so as to say, associated with stones, and it occurs in tubular structure. That is what it is. If the stone stays there for a longer time, it can lead to stasis and infection, as occurs in any case. Okay, so that is again a second cause of parotitis, that is bacterial parotitis due to stasis of secondary to the stone, or sometimes the stricture. These are basically all the causes. So in the history part, you have to just ask that if there is a pain and fever present or not. Pain, fever, tenderness. The history, pain and fever, tenderness in the case of examination. That is it. So rule out infections, inflammatory pathology. Okay. Stones also, and you also have to ask the pain, the nature of the pain. So if there is an infection, the pain is localized to the region. If there is a colicky pain, as I said, it occurs classically when someone is asked to chew or eat or salivation occurs. Classically described as sucking a lemon. So when someone has something that is more citrus in nature, there is increased salivation. Obviously, increased salivation leads to increased production of saliva, which does not go ahead, basically leading to a blockage of the secretion and a colicky pain, which increases suddenly with salivation and decreases gradually as the stone dislodges and lets the saliva to come out. Okay, and so that way, obviously, if there is a presence of parotitis secondary to a stone, or bacterial infection present secondary to a stone, if we see the opening of the duct, that is again the second molar tooth, there can be secretion of pus coming out because of infection, or viscid secretion coming out from the opening of the duct. Okay. That is the basic symptomatology of an infection: pain, fever, tenderness, pus coming out. Sudden in onset, obviously, because these are sudden in onset, sudden acute in onset. These things rule out or include infection in. Okay. In a neoplasm, contrary, that is just a swelling. There is nothing else. Neoplasm is just a painless swelling. Okay. The other types of neoplasm that you should know apart from pleomorphic adenoid. What is the second most common type of benign tumor? Obviously, you guys are reading for NEET, so you need to know that second most common benign tumor.
Warthin's tumor.
Yeah. So, and what is the most common type of malignant tumor?
Mucoepithelioid cancer.
Epidermoid. So, and what is the most common tumor of parotid? Overall. What is the most common tumor?
Pleomorphic adenoma.
Yes. So to sum it up, parotid per se in any salivary gland, if you say most of the tumors are benign, the most common location among all the salivary glands of the tumors is parotid. The most of the tumors of salivary glands are benign. The most common location of tumor in the salivary gland is the parotid. In the parotid, again, 80% are benign. Out of those 80%, almost 80% are pleomorphic adenoma. Okay. So overall, the most common tumor in parotid gland or in any salivary gland is pleomorphic adenoma. Okay. In the submandibular salivary gland, also the most common tumor is pleomorphic adenoma, and most of them are benign. In the sublingual gland, it is about a 50-50% proportion of benign and malignant tumor. So you can't say any most common. In the minor salivary glands, that are salivary glands in the palate, soft and hard palate, most common tumor is a malignant tumor. So out of all the salivary glands, if we come in everything, most common tumor is a benign tumor, which is commonly located in the pleomorphic adenoma. And if you have to say the most common tumor of all the salivary glands, again this is pleomorphic adenoma, either in the parotid or sublingual or submandibular, anywhere. It can occur anywhere. Pleomorphic adenoma is a pathological diagnosis. It can occur anywhere in all the glands. Okay. Most common tumor is pleomorphic adenoma. Most common location is parotid gland. In the submandibular, as I said, again it is parotid, again it's pleomorphic. In the minor salivary gland, just it's a CAD phenomenon. So most common tumor of minor salivary glands if asked, then it is malignancy or a neoplastic etiology of malignant origin. Okay. Out of all the benign tumors, the second most common benign tumor is Warthin's tumor, which is present invariably exclusively in the parotid. So understand that. All glands, parotid gland most common is pleomorphic, second most common is Warthin's, which occurs mostly only in parotid. It doesn't occur in submandibular gland. Submandibular gland can have pleomorphic, it cannot have Warthin's. Okay. And most common malignancy, that is malignant tumor, is mucoepidermoid. Okay. Mucoepidermoid tumor is the most common tumor of all salivary glands and also of parotid gland. See, whatever is of all is of parotid, because most common overall is parotid. So whatever you tell of all is of parotid, and whatever is of parotid is of all. That is generally the case. But if you come to individual glands like the submandibular gland, again the most common is mucoepidermoid and pleomorphic. But if you come to something like minor salivary glands, it's a malignant tumor. Okay. Yeah. So that is all about the classification, as we know that. So a Warthin's tumor and a pleomorphic adenoma has almost the same presentation. So as to say, both of them are basically all tumors of the parotid gland are pathological diagnosis. Pleomorphic is basically known as pleomorphic because what is the pathology? The histopathology seen in pleomorphic adenoma. What do we mean by pleomorphic?
Mixed
More
tissues
than
are seen.
Yeah, sorry. Pleomorphic means a variety of forms seen or variety of distribution seen inside the gland. That is, a stromal element can be seen, an epithelial element is seen, and a myxoid element or a myxomatous element is seen. That is cartilaginous, stromal, and epithelial element. A Warthin's tumor, the other name of Warthin's tumor is? What is the other name of Warthin's tumor? Yeah, very good. Warthin's tumor, the other name is adenolymphoma. Yeah. The Warthin's tumor is adenolymphoma. Well, what does that mean? Just to divide the name, it is basically a tumor which has adenomatous and lymphoma as contents. So adenolymphoma or Warthin's tumor, if you see in the histopathology, there is presence of papillary stroma along with papillary cells or papillary projections along with lymphoid stroma. The adenomatous content, that is in the form of papillary epithelial lining or papillary projections, along with lymphomatous stroma. So lympho and adenoma. Okay, adenolymphoma. That is how you divide. Pleomorphic adenoma is, as I said, what it is. These are the two common things. In mucoepidermoid carcinoma, same. Mucoepidermoid means there are mucoid cells and epidermoid cells, and there is carcinomatous stroma. That is how you. These are all basically pathological terms. Okay. So, but clinically coming, because they are doing clinical examination, so clinically coming down, a pleomorphic adenoma and a Warthin's tumor both are painless swelling, gradually increasing in size, with no pain, with no features of any complications, skin palsy or anything, nothing like that. There is no other complaint apart from painless, gradually increasing swelling. There is no sudden increase in size also. So to contrast both of them, what are the features? Okay. So you understand that basically I'm trying to make you understand the whole pathophysiology and the symptoms, because I think so you won't be needing to read also the chapters after these. I've already gone through the anatomy, the physiology part, the histopathology part of the various tumors, also the clinical features differentiating into. Can someone tell me what are the classical epidemiological features of Warthin's tumor? Epidemiological first to say. Is it common in male, female, in what age group, and in what conditions? Warthin's tumor. This is also a very good NEET
More
question.
common in males.
Yeah,
And
and
to female it is 4:1.
yes, then males, I got that then.
Age group is about 60 years.
Yeah, something else. A lot of guys have replied me, so most of them are true. Some of them are partly wrong. So yeah, so the first to submit for everyone. So Warthin's tumor is commonly seen in males 60 years plus. So most probably 5th or 6th decades, not before that, not 30 or 40 years as someone pointed out. It is in 50s, 50 plus, or commonly 60 years. Males, classically associated with smoking. So these are three features: male, smoker, 50-60 years, male. Pleomorphic adenoma in 40 to 50 years. The rough estimate, so don't take age as the predictive factor, but pleomorphic adenoma is Watkins is classically seen in males. Pleomorphic adenoma has no such thing, age group, and smoking is more factor that goes in terms of pleomorphic, Watkins tumor. Not pleomorphic adenoma. Smoking is more for Watkins tumor. Also, Watkins tumor can be bilateral in about 10 to 20% of the cases. That is a very important point. Pleomorphic adenoma is generally unilateral in about 90-25% of cases. It is very rare to have a pleomorphic adenoma to be bilateral, but Watkins can be bilateral. That's another distinguishing point. You're asking negative history. Also, Watkins tumor is basically something that is lymphomatous element present inside it. Okay, so logically speaking, as in parotitis or mumps, if there is a URTI preceding it, there is presence of bilateral swelling suddenly occurring. Similarly, if the patient has some kind of infection of upper respiratory tract or something like that, because of the lymphoid tissue is basically just something that is lymphoid in nature, so it swells up or there is an inflammation of lymphoid tissue whenever there is an infection. So associated with a sudden increase in size in bilateral or unilateral gland with infection is a feature of Watkins tumor. Because there are lymphoid elements. You get the concept behind it. Because of lymphoid elements, there will be sudden increase in size secondary to a URT or LIT present, either unilateral or bilaterally. Bilaterally in only 10%, not common. It is 10%, but it is more common as compared to pleomorphic. It is still rare. Generally, it is unilateral only, sudden increase in size. Contrary, if there is sudden increase in size in a pleomorphic adenoma, it is suggestive of carcinomatous change. Okay. The sudden increase in size in pleomorphic adenoma suggestive of malignancy or carcinomatous change. Sudden increase in Watkins tumor it can be suggestive of a preceding URTI. So the next question is: can sudden increase in size be a suggestive feature of malignancy in Watkins tumor? Yes or no? Can a sudden increase in size be a suggestive feature of Watkins tumor, and if how can we differentiate between those? Pleomorphic sudden increase in size means a carcinomatous change. But what does increase in size in a Watkins mean? Does increase in size in a Watkins tumor mean a malignant change, yes or no? Okay. So Watkins tumor, pleomorphic adenoma per se, is a condition that is pre-malignant, so as to say. But Watkins tumor is not a pre-malignant condition. That is a difference, a major key difference in terms of management of both of them. Pleomorphic adenoma can convert into carcinoma ex pleomorphic adenoma, that is a malignant change of the pleomorphic adenoma in about 10% of cases, gradually, obviously. But Watkins is never pre-malignant, it does not change into malignancy. So pleomorphic adenoma obviously has to be resected always and obviously has to be treated, but Watkins can be observed in a few cases. Okay, but neither of them are observed ever. Very rarely is Watkins also observed. Only in cases where it is a 80-year-old male who cannot tolerate GA and everything. But Watkins is also generally excised. Can someone tell me why? Or to put it in other words, how will you differentiate? How will you definitely differentiate a patient if the patient has a pleomorphic adenoma or a Watkins tumor? What is the definitive differentiating feature?
Technetium per technet scan.
Okay, one is technetium 99 scanning. So for everyone, just to know that technetium 99 scanning gives a hot spot because of lymphomatous element in adrenal lymphoma, that is Watkins tumor, and a cold spot in all other cases. But that is all other cases. But also, you can't do technetium 99 scanning everywhere, always. So what is something else that is definitive, that commonly used? Is FNAC a definitive feature? Is writing FNAC? Is FNAC a definitive feature? You can differentiate between variety of pathologies. Yes or no? Come on, please reply. One can chat out at least. Anyways, so FNAC is something that can point you towards something, but not a definitive feature. The only so in diagnosis, the only thing that definitively differentiates is a histopathology. So a pathological specimen, a histopathological specimen can only differentiate. As I said, all these terms, all these you can differentiate something that is infectious or neoplastic. But in all the neoplasms, all the names of all the neoplasms are basically based on the histopathological character. Pleomorphic, mucoepidermoid, adenolymphoma, all these are histological names or histological characteristics. So you cannot differentiate on the basis of any other feature. Even FNAC does not give definitive diagnosis. FNAC has a lot of shortcomings. The most common of it is FNAC has a very small amount of specimen taken in it, and by that the amount of tissue that is taken in cannot be predictive of the whole gland. And a common misconception seen among variety of pathologies is that pleomorphic adenoma, for example, has a variety of elements. So you can't definitely say that even if you see all the elements, it is also seen in something like pleomorphic carcinoma. That is the carcinoma in pleomorphic adenoma. A Warthin's tumor has a lymphoid tissue in it, but there is also lymphoid tissue present in lymphomas, which are also arising from parotid gland. So you cannot differentiate on the basis of FNAC unless you have a histopathology. And how can you get a histopathology of a parotid gland? You do. There is nothing known as incisional biopsy or a true cut biopsy or a punch biopsy in a parotid gland. You never do any biopsies. The only biopsy that you can do is superficial parotidectomy. So ultimately, to confirm your diagnosis, coming back to my first point, whether it's a pleomorphic adenoma or a Warthin's tumor, you have to confirm it, because if it turns out to be a pleomorphic adenoma, it can be a pre-malignant condition which you will have to excise. The Warthin's tumor, if you are very sure, sometimes you can observe, but most of the cases you are not sure, so you will have to remove it. You will have to do something like a superficial parotidectomy, basically operate. That is also the treatment of choice for both of them. Superficial parotidectomy, that is also the definitive diagnostic method. I'm not saying the investigation of choice. The investigation of choice is FNAC, so as to investigate and come to some kind of diagnosis. But the definitive diagnosis can occur, the gold standard, so as to say, or the treatment of choice, both are the same. That is superficial parotidectomy in both of the cases, because then only you can remove it and see whether the capsule invasion is present, the malignant changes are present, and what all things are present. So all these pathological changes. Okay, so that is why I was asking. So for both of them, either way, you're just coming to diagnosis clinically that it is most probably a parotid swelling, which can be most probably pleomorphic, but can be Warthin's or can be something like mucoepidermoid carcinoma. Because also another characteristic feature of salivary gland swellings are all of them are very indolent, so as to say very slow growing, whether it be a malignant swelling or a non-malignant or a benign swelling like pleomorphic adenoma. Even carcinoma swelling are very slow growing, except only an orally swelling arising from the pleomorphic adenoma per se. So if there's a primary pleomorphic adenoma, the secondary carcinoma is very fast growing, but all other carcinomas like a mucoepidermoid carcinoma being the most common type is also slow growing. So for mostly everything, the treatment of choice or the diagnostic method is the same. Intraoperatively, if you go and see and you find that it's a swelling that is more looking like carcinomatous, you go and remove the deep lobe also. But per se, it is the same. Okay, so you'll have to open the patient anyways. Any parotid swelling, open the patient so as to confirm and so as to see. And so this brings us to the points that which lead us or to tell us that what are the points suggestive of a change in the nature from a benign tumor to malignant tumor. What are the points that suggest us that this is a swelling that is turning malignant? There are a few 4 or 5 key points. What are the key points?
Sudden increase in size,
Yes. And
fixity to the surrounding tissue,
then
Associated with pain.
Lymph node
Then
involvement,
a very
facial
important
nerve
point.
involvement.
Facial nerve involvement. Very good. So again, generalizing things, then the whole system anywhere, as you say, as I am trying to tell, whether it's a symptomatology, you can divide it into inflammatory neoplastic cause, whether it's a swelling, you can say site size, shape, etc. Similarly, anywhere in the body, changes of a benign swelling into malignant swelling or benign tumor into malignant tumor includes a few things. One, a sudden increase in size. Second, a sudden increase in pain. Third, fixity to surrounding structures. Fourth, involvement of surrounding structures. These are the four things. Whether it's a CA breast, it's like increase in size in the CA breast, or pain developing, ulceration developing, development of lymphadenopathy, development of pectoris, fixated pectoris major muscle. Similarly, over here, a sudden increase in pain, sudden increase in size, sudden fixity to the skin or the masseter muscle, whatever is surrounding it. That is the basic funda. And whatever is surrounding it involving that, the involvement of facial nerve into facial nerve paralysis. These are the four signs or five signs, so as to say, which indicate that the change is from benign to malignant. A sudden increase in pain, sudden increase in size, sudden increase in sudden fixity to skin or masseter muscle. Masseter muscle fixity leads to trismus. So how do you see it? A trismus appearing. Fixity to skin is clinically seen as ulceration and nodules or something of that happening, or just a fixity to skin can also be seen sometimes. But masseter is trismus. And facial nerve involvement. The facial nerve involvement, and I think all of you know how to examine the facial nerve. What are the features you see to examine the facial nerve? मेडिसिन में पढ़ा होगा कहीं तो पढ़ा था ना फीचर तो फेशियल nerve palsy whatever it is
drooping of the angle of mouth, nasolabial folds are absent.
and
Ptosis.
and clinically what signs do you do, as in what tests are you doing?
Ask the patient to blow the mouth, shut the eyes.
Yes, then
Lift eyebrows. One, wrinkling of forehead.
yeah, so the features, so as to say, on the basis of history, the features are facial nerve involvement are drooping of eyelid, that is ptosis, as I pointed out, drooping of the lip, that is drooling of saliva, so as to say, in terms of the symptoms, absence of facial expression over the whole face, inability to whistle. These are the 4 or 5 common history symptoms you can ask. But the patient is there is ptosis, there is drooping or drooling of saliva, there is loss of facial expressions on the one side of the face. Clinically or examination wise, there are the 5 classical signs and 5 muscles that are asked, all to 1 branches, so as to say. So the first thing is inability to raise the eyebrows. So I will ask my patient to raise the eyebrows. So if there is loss of wrinkling on raising the eyebrows, there is loss of the frontalis part of the occipital frontalis, which is supplied by the frontal division of the facial. As I said, there are 5 divisions. Second is inability to blow the inability to blow mouth, just the blow mouth, not whistles per se, blow. So that is what we do. That is buccinator muscle. Okay, that is the second important. The third is inability to smile, inability to show his teeth, not clench teeth. Okay, so the common mistake done over here is persons say that inability to clench the teeth. So clenching the teeth is you are contracting the masseter muscle. This is masseter muscle is a muscle of supplied by, is it supplied by facial nerve?
Trigeminal.
Yeah, that is what I'm going to do. The masseter muscle is a muscle of mastication supplied by the mandibular nerve, that is the trigeminal nerve. It is not a muscle of facial expression. So raising the eyebrow, blowing or blowing the mouth, or asking the person to show his teeth, not clench his teeth. Let ask this, to show his teeth or smile, so as to say any of whatever you want to see, to show his teeth or smile, not clench the teeth. That is where the examiner will take you. Okay. Asking the person to extend his neck, that is used for the platysma. Okay. So these are the common muscles used: occipital lobe of occipital frontalis, or frontal lobe of occipital frontalis. Sorry, buccinator muscle to blow. You can use the to show his teeth. The muscle, I forgot the muscle to show his teeth. Sorry, to extend it is platysma. Other muscles are obviously there. You can ask the person to tightly shut his eyebrows, or if the person is able to tightly shut his eyes, then you can try yourself in the case of palpation. After tightly shutting the eyes, you can try with the help of your fingers to open the eyes. These methods will be asked. See, The first thing is just this. There is an inspectory method or a palpatory method, whatever say you want to feel the eyebrows, the wrinkling of the forehead maybe. But the second method, like tightly shutting the eyes, is first an inspectory method. This is followed by trying to open the eyes. If the patient is able to still shut his eyes, then the facial nerve is completely intact, or there may be partial paralysis or paresis, so as to say, if the patient, if you are able to open the eyes with the help of your fingers. So that's again a palpatory method, not an inspectory method. The difference. To blow his cheeks, inspection. This is what it is. If he is able to blow his cheek, then with the help of my hand, I will try to deflate his cheek. That is what you say. If he is still able to do that, then it is probable that there is no paralysis, or else there can be mild paralysis. These are things you do. You have to palpate them. Okay. And as I said, smile or extend the neck. These are 4 or 5 tests done for facial nerve. That is why we rule out facial nerve palsy. You rule out malignancy. These symptoms are ruled out. So, to come to a diagnosis of pleomorphic adenoma, as I said, the diagnostic is biopsy. The treatment of choice is superficial parotidectomy. And the plane in which you do superficial parotidectomy is, what is the name of that plane? The plane in which you do superficial parotidectomy is known as, I already started off with that plane actually.
Facial
Pathology.
plane of Pettis.
Yeah, exactly. The Pettis facial plane is something that which is used for the dissection or superficial parotidectomy. Okay. In cases of in majority of the cases, if someone asks, the aim of the operation of any parotid operation is to preserve the facial nerve, to let it not damage or minimal damage as much as possible. Even in cases of parasympathetic change, you do not remove the facial nerve unless and until it is involved pre-operatively. That is, if evidence of facial nerve palsy pre-operatively, then you can remove it and then reconstruct it with the help of greater auricular nerve or some other method or some other grafting that you can use. Commonly used is greater auricular nerve. Okay? But overall, by and far, if there is no preoperatively involvement, or the tumor is not very large, or there is no invasion, even in case of invasion, sometimes our basic aim is to preserve the facial nerve. Because even in case of invasion of the facial nerve, we can use postoperative radiotherapy to shrink the tumor if there is presence surrounding the facial nerve. So, a basic aim is to preserve the facial nerve by and far possible. The various operations of parotid are superficial parotidectomy, total conservative parotidectomy, that is total parotidectomy, superficial and deep, which conserving the facial nerve, and radical parotidectomy, that is removing everything, both the lobes and the facial nerve, that is radical. Okay. And newer advances, in terms of newer advances, the newer operation is extracapsular dissection. Okay. Extracapsular dissection of the swelling or the lumps, so as to say, so you just remove the capsule, you remove the tumor outside the capsule, you keep the capsule as it is of the tumor, you just remove the tumor and 1 centimeter surrounding the tumor and keep the capsule intact, or so as to call the parotid fascia that is present, that is basically the capsule, the investing in the deep layer, as I said, intact, and remove the tumor in toto, and then again suture the parotid fascia that you have incised. This is the advantage of this, so as to say, is to prevent Frey's syndrome. Okay. So the complication of surgery, the most important complication is Frey's syndrome. The most common is serum of formation. That is not important for you. So what is Frey's syndrome? That is basically the last part of the whole topic. What is Frey's syndrome? The other name of Frey's syndrome.
Gustatory sweating.
What is crocodile tears? So is that the same thing? Is crocodile tears and Frey's syndrome the same thing? Just to point out, I know everyone knows that, but that is because you are currently hearing me asking it that way. Generally, what happens is the examiner starts asking crocodile tears, and you start replying Frey syndrome. Okay, crocodile tears is not the same. Crocodile tears is while eating or while swallowing, there is presence of overflowing of tears from the lacrimal gland. That is apparent inhibition of the lacrimal gland, the fiber supplying the lacrimal gland, and not the parotid gland. Okay, so that is the problem with it. If the parotid gland has a variety of fibers that are postganglionic parasympathetic fibers, postganglionic cholinergic parasympathetic fibers, which we inadvertently damage or remove during the surgery because we remove the gland, so as to say. So the postganglionic cholinergic parasympathetic fibers are removed or damaged, but ultimately they regenerate about after 6 months after the surgery, and they regenerate, but they have nothing to supply. But they still give supply through cholinergic paraganglionic fibers or postganglionic fibers, and they supply the instead of the salivary glands, the sweat glands, which are again cholinergic in nature. So you all know that if you go back to physiology, that the only glands that are postganglionic and cholinergic are the sweat glands. Okay, so still cholinergic in nature, those fibers instead of supplying the salivary glands supply sweat glands, and when there is salivation from during eating, this presence of flushing or sweating at the presence of the parotid gland both sides, which is gustatory sweating and not crocodile tears, gustatory sweating. And also other name is Frey's syndrome or auriculotemporal syndrome, because the nerve involved during this is auriculotemporal nerve. Okay, auriculotemporal syndrome, Frey's syndrome, gustatory sweating, aberrant regeneration of postganglionic parasympathetic fibers supplying salivary gland to the sweat glands of the skin leading to flushing. That is what it is, and it is prevented through a method nowadays known as extracapsular or extracorporeal dissection, as I already pointed out. Otherwise, there is generally no preventive method. The treatment method is also very vague. You can sometimes use a parasympathetic or sometimes use Botox, botulinum toxin towards it, and just paralyze the nerve. This is all that you need to know about the whole parotid gland. You can now easily write an answer on parotid gland. Also, you know what is pleomorphic adenoma, its etiology, its pathology, the clinical symptoms, the diagnostic features, the treatment part, what else are the symptoms suggestive of malignancy, suggestive of facial nerve palsy, what is Warthin's tumor, its pathology, and its classical clinical syndrome. Apart from it, the treatment part and everything is same. We will describe almost everything. Mucoepidermoid carcinoma is not asked per se in the theory or in the practicals or in the NEET anywhere. The only question in mucoepidermoid carcinoma is it's the most common malignant tumor of the salivary glands person. Okay? And another, because we're talking about NEET questions, and just to cover NEET person and just to finish off the whole salivary gland in every aspect for you, there's a tumor which is known for its perineural invasion. That is neural invasion, malignant tumor. That is what, can you see the name of it? Neural invasion.
Adenoid cystic carcinoma.
So adenoid cystic carcinoma is the name of the tumor which is known for its perineural invasion. Also, it's the most common carcinoma seen in certain glands. But commonly, the only thing you need to know is it is known for perineural invasion. That is all you need to know. And if someone has asked me that can the use of muscle flap prevent Frey syndrome? Definitively no, but yes, sometimes in Frey syndrome you use a thick skin flap, or sometimes you use sternocleidomastoid and mastoid flap or muscle flaps to put it at the space where there is the parotid gland, just so as to prevent the direct contact of the nerves which are now bare, and so that it doesn't go to the skin and regenerate it through connection to the skin. So just something that comes between the direct nerve and the skin, so as to prevent Frey syndrome. But yeah, it is not proven. It is used, sometimes it is not used, but you can say that yes, it is a method. Okay, so just so as to now confirm that you guys know all this, and you can present the swelling of parotid gland. There is this presentation, so we rule out one by one everything, and it will help you gradually to know what is it. So the first thing over here, it's the age. As you all know, the age, as I said, pleomorphic, Warthin, and infections. Infections, mumps is an age group, that is younger age group. It can occur in older age group also, and the stone or siloadenitis can occur in any age group. So there is no specification. Male, it can point toward Warthin, it can point towards Warthin. Anyway, it can go. Liberal, Mumbai, everything is fine. The same things. Swelling below the left ear, okay, that is also okay. The next thing, this comes the tricky part from history. For relatively asymptomatic for 1 year, with a slow growing swelling, infections are ruled out generally, and it is incident in onset, small in size, increasing to current size, or again a progressive, not associated with pain. Pain, you rule out a variety of things. Pain is, it is not an infectious pathology, it is not an autoimmune pathology, it is not something that is siloadenitis, it is not even something that is like malignant change in the pleomorphic adenoma. All those things are ruled out by pain. Okay, no complaint of increase in size or pain with food intake. That is again stones. Okay, no suggestive facial no palsy. This is a short case. You don't have to write everything in detail. Just have to quickly mention the negative history, the small positive history, small negative history. Negative history just facial no palsy or rapid increase in size. These two things will rule out malignancy and facial no palsy for you. You just have to see these things. You don't have to mention the findings. Okay, no history suggestive of facial no palsy or rapid increase in size. If the examiner asks, then you have to mention it. That is a short case. That is why. Okay, similar swelling of the opposite side, same side, or the neck. Opposite side, because as I said, Warthin's. Same side history is important because of recurrence occurring in pleomorphic adenoma. One point we missed out. Why is recurrence common in pleomorphic adenoma? Is recurrence common in pleomorphic adenoma? Yes, I already answered that. But why is it common?
Because capsule is deficient at some places and cells can be following
Yes.
infection.
So that's the right thing. So basically, the capsule of the tumor, not the parotid gland per se. There is a black capsule around the tumor, that's the pleomorphic adenoma, which has various deficiencies or dehiscence in it. So there are various holes, so as to say, which lead to finger-like projections outside the capsule. The presence of dehiscences and finger-like projections outside the capsule, we are not able to fully remove the tumor a lot of times, and that is why pleomorphic adenoma is known for its recurrences. And in recurrences, it's a very bad thing. Recurrences generally you have to do a total complete excision of the gland along with maybe involvement of facial nerve. So you have to take care that you remove the tumor with about 1 centimeter margin of the tumor as much as possible so as to prevent the chances of recurrence. That is why no issue of similar swelling at the same site. There can be a recurrent pleomorphic adenoma so as to say. This is a common thing to occur. Okay. No history of diabetes, hypertension, TB. Okay. Another thing that I forgot is there is something known as idiopathic swelling of the parotid gland, a very common occurrence in diabetics and alcoholics. Okay, diabetics and alcoholics. Does someone ask if idiopathic swelling of the salivary gland common in diabetics and alcoholics? Uncommon per se, but if occurring idiopathically, these are the things. It is just a parotid gland swelling. If you do a histopathology, there is nothing like pleomorphic adenoma. There is no change in it. The pathology is same. That is why it is an idiopathic swelling of just the parotid gland. Smoking is for Warthin's tumor. Family history is not obviously. The standard examination part, you can skip that. The important thing over here. Okay, so yeah, someone is asking me that if you do a superficial parotidectomy, that why is there residues or recurrence still? Superficial parotidectomy is everything about the facial-venous plane of patty, but nowadays, as I said, if we try to prevent the whole excision, we do as much as possible. But sometimes, even if you do the whole excision, like the whole superficial part, there are pseudopods, so as to say, finger-like projections which occur around the facial nerve or go inside the deep gland. Okay, we can't say that. Another important thing which will come in the examination part is the deep gland can also be involved, that is below the facial nerve in the pleomorphic adenoma or in other cases. It is rare in 10% of cases only, but it can be involved. That is why even after superficial parotidectomy, we cannot definitely say that recurrence won't occur unless you do a total parotidectomy with facial nerve, that is a radical operation, then only you can say that there will be no recurrence. Otherwise, there can still be recurrence. Okay? Because there are still some or the other pieces present somewhere. So nowadays, it's a more conservative approach on extracapsular dissection with 1 centimeter or 2 centimeter margin, because that has shown to be a similar results as a superficial dissection or superficial parotidectomy. Because in a superficial case, you have to dissect more around the facial nerve, here just around the gland. Still, the recurrence is the same. So why dissect more? That is the basic understanding behind it. Here in the inspection part, what is the thing that you have to stress is there is a normal skin over the swelling. Normal skin over the swelling rules out any sudden increase in size because of any infections like secondary to Warthin's or parotitis. And the other important thing, it obliterates the hollow behind the earlobe. Okay, so in the case of an examination part, the examiner around the inspection part, or just at the end of the history, will ask you that why are you saying that it's a parotid swelling only. Okay. So the differential diagnosis of a swelling in that region, apart from parotid swellings, are a couple of them. Okay. The most common, can someone tell me differential diagnosis of a parotid region swelling and not being parotid, non-parotid swellings? Any one differential diagnosis?
Lymph node enlargement.
Lymph node and
Sorry, I didn't hear anything. Maybe
Obliteration of retromandibular groove in the
That-
parotid swelling.
that is the feature. But what is the differential diagnosis? Someone said something, I didn't hear it.
lymph.
Lymph.
Yeah, lymph node swellings. Exactly. So the most common differential diagnosis in the parotid region, non-parotid, is lymph nodes. That is, again, if we go systematically from superficial to deep, the skin superiorly, masseter muscle inferiorly, and lymph nodes, preauricular lymph nodes, and upper cervical lymph nodes present. Okay, upper cervical lymph nodes is present here near the tail of the parotid gland, and the preauricular here near the anterior part of the parotid gland. So for a pleomorphic adenoma, it's the preauricular lymph node which is confusing. For the Watson's tumor, because the most common site of Watson's tumor is the tail of the parotid gland. Again, the most common site of Watson's is tail. In for a Watson's tumor is tail, so a upper cervical lymph node. But the differentiating feature is none of these obliterate the hollow behind the ear lobule, or none of these push the ear lobule upward. So this is the ear lobule, this is the hollow between, classically seen between the angle of the mandible and the mastoid tip. If you palpate your angle of mandible and mastoid tip, you will see that the hollow present over here. This is obliterated in the parotid gland. This should be your first answer, and along with it, that most probably the most common swelling in the parotid region, as I described the boundaries of the parotid region, zygomatic arch, mandible, mastoid, midpoint. This parotid region, the most common swelling in the parotid region is parotid gland. If not the parotid gland, it's the lymph node, but the supportive feature is that it obliterates the hollow of the ear lobule, so it's not a lymph node. In palpation, you will come that the size and the mobility is more for a lymph node than the parotid gland. Okay, that I will discuss in the palpation part. But so these are the features of parotid swelling, parotid region swellings, differential diagnosis, and parotid being it specifically. The second or the third most common swelling over there is lipoma or a sebaceous cyst developing on the skin. But these things are rarer, and if they are, you can easily differentiate them on the basis of lipoma and sebaceous cyst. Okay, I'm not going into those things. The important thing is lymph nodes. Okay, so again repeating, a lymph node is present more superficially than the parotid gland, one, thus, and a small size. So thus, when it enlarges, it does not specifically obliterate the hollow of the ear lobule. The hollow of the ear lobule is the space between the angle of the mandible and the mastoid tip. It does not obliterate the hollow of the ear lobule. That is why it is not a parotid. It is a parotid or not a parotid swelling. Okay, if it obliterates, it's a parotid. If it does not obliterate, it can be a lymph node swelling. And the first point should obviously be that the most common swelling in the parotid region, that is the boundaries of the parotid region, is a parotid swelling per se. In the parotid region, the most common swelling is the parotid swelling, if not a lymph node swelling, but it does not obliterate the groove. And in terms of palpation, it is more mobile. Lymph node is more mobile, while the parotid gland is less mobile. So these 3 points: the location, the obliteration of the groove, and the mobility. Okay, so it's an important differential diagnosis. So that is why you have to rule out those things. Also in the history part, if you can see, notice the swelling below and behind the ear. You have to mention that because it can be anything. So you can't just say that it is a parotid swelling only, but to support the diagnosis, yes, on the history basis, most common site or most common thing in the parotid region occurring is the parotid swelling. That is why you have seen this. Okay, you can't definitively say the boundaries on the basis of history only, but this is a supportive point of a parotid swelling. Yes, so whatever size, shape, location, margin, skin. Size, shape, location, margin, skin. Skin is important, and obliterates a hollow is important. This will point you towards the parotid swelling. That is it. No other swelling visible. Again, so as to see bilateral swelling present or not, something like that. Intraorally, no bulge is seen in the tonsillar paper or uvula. Now, the deep lobe of the parotid gland or the deep lobe of the submandibular gland, both of them are present in the parapharyngeal space. Okay, so for the deep lobe involvement, if there is just a swelling in the deep lobe and not in the superficial lobe, it occurs in the parapharyngeal space and it will deviate the uvula to the opposite side. The tonsillar pillar will have a bulge over there, and the uvula will be deviated to the opposite side. Okay. Intraoral examination is important to mention for deep lobe involvement. Palpation, as you start, temperature, tenderness, obviously no tenderness, no temperature, so obviously no infections. Again, in the parotid region, an important thing, form, and second important thing. By form is points toward the benign swelling. Okay, a benign swelling. Hard is a malignant swelling. Form is a benign swelling. Form and hard. Okay, non-tender, again a swelling that is not infected, so as to say, or no parotitis seen. Swelling is partly mobile with curtain sign positive. It is the classical sign, the only sign actually in the parotid gland present, parotid whole thing present. What is the curtain sign? I already mentioned the basic funda behind it. If you guys remember the anatomy, and if you guys remember what is the difference between lymph node and this, what is the curtain sign?
Tumor does not go beyond the zygomatic bone.
Why does that happen?
Because the investing layer of the fascia is attached to the zygomatic arch.
Excellent. Very genuinely very happy that you guys have read that much and you know this much about the salivary glands. My basic aim by this was that even if you don't know anything, that by just this 1.5 hour lecture, you can know everything NEET with respect to theory, practical, or NEET, and with respect to anatomy and physiology and whatever things you can cover the lateral learnings. Very good thing that you know these things. That yes, the curtain sign is basically a sign in which is known when the parotid gland cannot be moved, or the parotid swelling cannot be moved above the zygomatic arch, because the investing layer, that is the layer covering the fascia or the layer covering the parotid gland, is firmly attached to the zygomatic arch. So you cannot move the swelling above the zygomatic arch. It is just partly mobile. It is not fully mobile in all directions. You cannot move it superiorly above the zygomatic arch. That is curtain sign. Okay. I hope you all got it. Curtain sign is the sign in which the parotid gland cannot be moved above the zygomatic arch. The reason for it is the attachment of investing layer of the fascia to the zygomatic arch, which is very firm. Okay. Just to answer a few questions that have been asked to me, a lymph node enlargement in that region is secondary to any infection. We cannot say that any infection. Firm and hard. So a firm swelling suggestive of benign, a hard swelling is suggestive of malignancy. Okay. So that fascia is adherent to the zygomatic bone. That is why it cannot move up, and that is why this is again the fourth feature, so as to say, curtain sign positive. So the three features are where the region specifically indicates the parotid swelling, the obliteration of the hollow, the mobility, and the curtain sign. These features indicate a parotid swelling. So on the basis of history and examination, now you can definitely see at the parotid swelling. Definitely by ruling out fever, any tenderness, any pain, any pus extrusion, any sudden inside, you can say that it's not an inflammatory swelling. It is a benign, or not say benign, a neoplast, a tumorous swelling of the parotid gland, and by ruling out any sudden increase in size or fixity to skin and masseter. So these things are malignancy indicative. So we ruled out non-parotid swellings, we came to parotid, we ruled out inflammatory swellings, we came to neoplastic, we ruled out any sudden increase in size from the history, any facial nerve involvement from the history, and again from the inspection part, the skin involvement and the masseter involvement. So how do you check for skin and masseter involvement? Again, the same concept as it was in the breast part. What is the test you will do for skin involvement and masseter involvement?
Asking the patient to clench the teeth and move the swelling for masseter involvement.
Okay, partly complete. I'm not denying it. Something that is missed. If someone has attended the last lecture for P major, there was something that was specific. For pectoralis major, that was specific to know that this is the test is happening properly. What was that? To confirm that.
First in the relaxed stage, and then we contract the muscle and try to move the swelling.
Exactly. So how do you confirm that the muscle is contracted? In pectoralis major muscle, for although you attended last class, in pectoralis major muscle, how do you confirm that?
By palpating the anterior axillary fold.
How do you confirm it over here?
Buccal.
See, for fixated to anything, okay, per se for fixated to any muscle, fixated to skin anywhere is the same. You cannot pinch the overlying skin and you cannot move the swelling independently of the skin. Okay, let's say a breast lump, for all those who missed the last class or for again a kind of a division. If the lump over the breast can be moved independently of the skin move, if you move the lump and it moves and the skin does not move, okay, or if it stays where it is, then it is independent. If the skin moves with it, that you can only move the lump by moving the overlying skin. It is one sign of fixated skin. The second sign is if you can pinch the skin easily, that is you can move the skin without moving the lump. That is the second method. Then the lump is free. Same over here. If you can pinch the skin above and over the lump, the skin is free. Or you can move the lump without moving the underlying skin. The skin is free. It is not involved. Okay. Yeah. For the muscle, there are three parts, as I said in the last time. Let's take the example of breast again. It's an easier example. So you first check whether the lump is movable or freely mobile, both with the direction of the fibers and across the direction of the fibers of the underlying muscle in the relaxed state. Then you ask the patient to make the muscle taut in whatever way it is in the B major by placing the hand on the sides of the waist and then pushing against it. You confirm that the muscle is taut, and then you again move the fiber in the direction across the direction. The first step, whatever underlying muscle it is, you'll try and move the lump in the relaxed state of the muscle, both in the fiber and across the fiber. For a breast lump, you'll try to move the lump both parallel to the direction of pectoralis major and perpendicular to the direction of the pectoralis major in the relaxed state. You would ask the patient to make the muscle taut. You will confirm that the muscle is taut by palpating the anterior axillary fold, and you'll again do the same thing in and across the direction. So 3 steps: relaxed state, confirming the taut state, and doing in the taut state. If in the second state, that is in the taut state, if it is not able to move freely, it can move across but cannot move independently, then it is obviously fixed. If it moves even in the taut state, it moves freely in the direction and across the direction of the fibers, then obviously it is fixed. Same in the masseter, you ask the patient to clench his teeth. You confirm it by palpating here, just in front of the tragus. You confirm that the teeth is clenched. You will see a bulge of the masseter muscle. By confirming by the bulge of the masseter muscle after clenching his teeth, you again move the muscle, move the lump, sorry. Then if it is mobile, then it is not fixed. It is not mobile, then it is fixed. Simple thing. Okay. Did everyone get that? How you do confirm the fixated masseter muscle? Someone asked me that is trismus a sign? No, trismus is not a definitive sign that masseter muscle is fixed. It is palpation. Trismus can be suggestive of masseter muscle fixity sometimes, but not always. Okay, it can be, it cannot be present. So skin fixity, masseter fixity, oral cavity examination, again the same thing. No bulge seen. That is why no bulge seen. No deviation of the uvula. That is an inspection in palpation. Again, because there is nothing, you do not palpate it inside. Otherwise, if there is a bulge seen, you digitally palpate it with your finger inside and one finger outside. One finger inside the tonsillar pillar and one finger in the hollow of the groove of the ear lobule, and then palpate the deep lobe. That is by digital palpation. BI digital palpation. But I don't think so you should do it, nor you should mention it. If asked, only and only to mention it, because it's a method nowadays not done. So better safe, put that is no abnormality in the oral cavity. If asked what is bidigital palpation, using the index finger and the thumb, bidigitally palpate inside the tonsillar pillar and in the hollow of the angle of the mouth. But refrain from saying it. That is my suggestion. Okay. Bidigital palpation. Okay. No cervical lymph node, no facial nerve involvement. Facial nerve involvement already tested. All those things the eyebrows, the closing of the eyes, confirming that the muscle is taut, and again trying to open the eyes, blowing the mouth, angle of the mouth, all those things. Okay, no cervical lymphadenopathy. In cases of malignancy, cervical lymphadenopathy can be present, otherwise it's not present. And finally, summary is the same. Okay, without any comorbid facial mass, all these things. The diagnosis is important. As I always repeat, the diagnosis should have three important things. What are those three things? Can someone please tell me now? After at least attending my 4 or 5 lectures, what are the basic things you should say in diagnosis?
Etiology, pathology, and the complications of any.
Yes, so there's the three things. Glad someone knows that. Actually, the 3-4 things that you should always tell is, first of all, you should start off by coming to the probable pathology that is present. In this case, a benign parotid swelling. Okay, you have to put the cause of that swelling being the pleomorphic adenoma in this case, and any complication. The complication of pleomorphic adenoma is malignancy. That is the only complication per se. Facial nerve involvement is a complication, but that is again indicative commonly of malignancy. It doesn't occur as such. So facial nerve involvement is included in when we say malignancy change. So a 45-year-old male, if any comorbidity with a 45-year-old non-smoker male or any male with a benign swelling of the left parotid gland or a left parotid benign swelling, whatever it is, most probably is the important word, because we cannot say definitively of pleomorphic adenoma with no suggestive malignancy change. Or it is asked that is all that the examiner wants from anyone to say. Okay. So I guess I hope that you guys got all the differentials that we have to do stepwise, the signs, the symptoms, and all you wanted to do in terms of all the salivary glands. Even in the submandibular salivary gland, the only topic important is stones, which I've already covered. In this case, the anatomy is also covered. The most common things are also covered. Someone asked me a very important question. What is the difference between firm and hard? Difference between firm and hard. Someone answer that. Anyone else can answer that? It's a very nice question.
Most tip is found. Frontal bone is hard.
Okay. Third thing, just to complete it, so there are basically 3 consistencies: soft, firm, and hard.
Soft lips.
If someone asks so as to say the common terminology that is used, when do you call the swelling soft? When it is firm, and when it is hard. The soft is when it is consistency is like the lips or the upper lips are commonly quoted out. Firm is like the tip of the nose, the cartilaginous part, not the bony part. Okay, this is firm, and this is hard. The mental bone is hard. Firm, soft, firm, hard. That is how you remember it. Someone said already also replied, firm is like muscle, so that is also right. Hard is like bony, that is also right. But those are what is like muscle then. So as to quantitatively or so as to demonstrate it easily, you can easily say soft, firm, hard. Okay, for everyone who didn't know, soft, firm, hard. So that was a very good question. These are basics, sometimes commonly asked. No one knows that. So do someone has any other doubts? Everything in a short time. It went a bit fast, but that is why I repeated a few of the things a lot of times, which are important things. Basically, the questions asked both in the practicals and the NEET. No doubts. I'm very glad that a lot of you stayed till the end of the lecture. We'll discuss what we have to do the next time in the group. So, thank you for now.